how would you define the CTV in this case? And to make matters worse, this is what we see when we actually image it. And we don't know the actual invasion. And to make matters even more problematic, you have to remember, this is inside the brain. So we must regard the entire structure as an organ at risk. And we really want to limit the CTV. If you think this sounds like a hard problem, then you're not alone. This is exactly what makes solving this issue so difficult and why GBMs are so hard to treat. What we do today is that we add a margin around the GTV concentrically of about 2 to 3 centimeters. But we still know that clonogenic GBM cells, they can be found further away, up to 4 centimeters, and that the spread appears anisotropic, as has been seen, for example, in this study. The point is that we have a visible GTV. This is how we delineate it, but it's not so difficult to understand why we're having a hard time solving this or curing these tumors if we have perhaps a true tumor extension that looks more like this. So now we understand what the problem is. Why is prognosis so poor? Well, high-grade gliomas, they grow quickly and they infiltrate the brain aggressively and diffusively. Curability is seemingly impossible because large regions of infiltrated normal tissue are invisible and they are thus never treated in the first place. So what can we do to improve treatment? If we map the entire tumor infiltration, we could perhaps adapt the CTV to better conform to the actual invasion. Basically, given the GTV, we want to find the actual invasion. And I want to then propose a fourth question. That is actually what we're going to focus on today. How well does the CTV match with the predicted tumor invasion? So the first step to finding an answer to this question was to try to model the actual tumor invasion. Now, being a physicist, I tried to use a physics-based tool to model this. I employed a Fischer-Kolmogorov equation that has been proposed and tested before. And if you're not up to par with your calculus, this might look like a kind of a complicated expression, but it's actually quite simple. It's simply a time differentiate equation where we have a change of cell count with time in some given region and how that changes. So how does the actual tumor grow and spread? We have two competing terms. One is the cell diffusion term. If you take a drop of dye, put it in water, it will naturally diffuse, exactly like a gas or like this liquid right here. Now, if you give this enough time, it will be completely homogeneous like this in the last picture. This is, of course, not as easy to do in a brain because the brain is not homogeneous, so we have to be a bit more careful with how we handle this diffusion term. Aside from the diffusion, we have proliferation. Cells can multiply, and the more cells you have, the faster the whole population grows. So it becomes a function as well of the proliferation term, the cell concentration. There's also a parameter K. This is the normal tissue tumor cell carrying capacity, and this limits the number of tumor cells we can have in a given volume. From a physical point of view, but also from a biological point of view, because normal tissue can only support as much tumor cells. So this equation, this gives us the change of tumor cells with time. We want to solve this equation and discretize it so we can use it in our computer. We use the finite difference time domain method for this. If this is the definition of differentiation, as the delta t goes to 0, well, if delta t is small enough, that's good enough for us. It becomes a numerical approximation, and it's also discretized, so we can solve it directly. And here's just an example of what it looks like when you take the entire equation and discretize it and solve it using these methods. This is for 1 dimension. Of course, we did this in 3, but just to get a picture of it. This is easy for a computer to solve. To show you what this looks like, I present with you here a 5 by 5 grid. These are pixels, and you can think that these white pixels represent white matter that were inside the brain here. And then we place a number of cells in some pixel, and you let the red intensity correlate to how many tumor cells you have. So step 1, perform a diffusion calculation. These cells are naturally going to diffuse into nearby pixels, lowering the number of cells in the middle, but increasing them in neighboring pixels. Then we do a proliferation calculation. This is just going to increase the number of tumor cells wherever there are already tumor cells. So we can think that they double or something like that. So the intensity changes. So this would be one time step. And then we just iterate this: diffusion, proliferation, diffusion, proliferation. And this is how we simulate how the tumor is growing and spreading in the brain. Of course, this was in 2 dimensions. To give you an example, we do this in 3 dimensions in the actual simulations, but the principle is exactly the same. So I talked about diffusion a lot. Now, the diffusion is governed by the diffusion coefficient. This is just a value, and the higher the value, the easier it is for tumor cells to move in that medium. The way I see the brain as a physicist is that it consists of 3 tissue types: white matter, gray matter, and the rest. So if you have an MRI scan of this is how I visualize it. And then we have a diffusion coefficient, which can take on one of 3 values: 1 for white matter, 1 for gray matter, and 0 for everything else. So 0 means that the tumor cells cannot move through that medium at all. So it could be outside the brain or barrier, or for example, metal barriers. So therefore, this diffusion coefficient becomes a function of which voxel you are actually in. The tissue types are segmented using the FAST SSL algorithm. This is an automated tissue segmentation. It's free to use, and it does have some good results. Now, we also wanted GTVs because we wanted to look at actual cases of high-grade gliomas. And to do this, we got access to the BRATS 2020 challenge data. Now, this was a deep learning challenge where different teams had a contest of which one could come up with the best algorithm to segment GTVs from a given data set. We had a team here from KTH here in Stockholm, which had some really good results, and we got access to the data. The actual true value of the data was not given publicly, so we had to use this deep learning data. Basically, we got a bunch of segmented GTVs, which we thought had some good quality to them. So we had some raw data. We segmented it into tissue type and GTV using automated methods, purely because of the sheer number of volume of data we had to deal with. And you combine these two to get something that is actually fit for simulation. But before we start to simulate tumors, we have to discuss 2 important ratios. These ratios, or parameters as I see them, govern exactly how the tumor will grow. So first is the diffusion to proliferation ratio. This characterizes the diffusiveness of the tumor. So T over rho. The higher the value, the more diffuse it grows. You can think of it that pretty much any solid tumor is going to have an extremely low value of this, whereas high-grade gliomas can actually have quite high values. So we have to consider this. So here's an example where the GTVs here delineated in pink are pretty comparable in volume, but the actual invasion of the nearby tissue is very much different. The second parameter is the white to gray matter diffusion ratio. This characterizes the anisotropy of the growth. So if these are equal to each other, it means we have a ratio of 1. This means that the tumor cells are going to traverse in white matter just as easily as in gray matter, and we're going to have an isotropic expansion, it's going to grow like a sphere, assuming there's no natural barrier in the way. But as this ratio increases, the tumor cells are more and more going to conform to the white matter. Now, there's a problem with this, and it is that actual experimental values for these, for actual cases of GBMs, are not well established. Clear consensus, perhaps because GBMs have an intrinsic variability in how they grow. Anyway, we tried to do this systematically, so we looked at the actual values that has been reported, and we tried all of them. So we have our model, we have our parameters. It's time to simulate some tumors. The idea was this. We take our segmented brain, we have our finished GTV already, and we place N0 cells at the center of mass of this GTV. This N0 is greater than 1 because we want to account for the phenomenon that tumors tend to need to reach a critical population before they actually start to diffuse away and spread. We place this number of cells in this one, and we let the tumor grow by iterating this equation with time. As we're doing this, we're keeping track of the 8,000 cell concentration contour. Why this contour? Remember that the MRI has a visibility threshold of this value, 8,000. This means that hypothetically, if we were to image our simulated tumor using MRI, we would only see up to this contour, this 8,000 line. In other words, this effectively becomes our GTV. So we keep growing this tumor, and we let it grow. We keep track of the isoline. And as soon as the isoline encompasses the pre-segmented tumor, we stop. So now you might wonder, what is the point of this? If we already have a GTV, what are we achieving by simulating another GTV on top of it? That is, I mean, it's not even conforming perfectly, overshooting it a little bit, because it always does by definition. Well, you must not forget that we actually simulate the entire tumor. I have only showed you the contour here. So what we get is the full tumor extension. And if we're successful, the GTVs will match fairly well, and then we can kind of start to assume that maybe this tumor extension is alike to value. So here's an overview of the process so far. We prepared we prepared a brain by segmenting it into tissue type and GTV, and we performed the simulation until we get the tissue type, normal tissue invasion. And we did this for all cases, and for every case, we did this 30 times, because we took all these different parameters for diffusiveness and anisotropy, all combinations of them, and tried them every time. Here's, just want to show you also an example what this looks like when we speed it up. I made some movies here. So I have different values for D over rho. So I think when I start the video, these brains are going to disappear. So you have to remember what you're seeing here. So for the first case, we have a very low diffusivity value. So it's going to grow pretty confined. It's not spreading so much. Whereas when we increase the diffusiveness value, it starts to grow more like a cloud and spreads out. So we have very high concentration in the middle, but we have also low concentrations far away, and it grows much slower as well, as you can see. You see the time scale is also actually different depending on how we do it. So for each case, we have 30 different simulated GTVs. Notice that this is a lot to keep track of. Anyway, this is important because we took only the best ones. We looked at all the different volumes of simulated tumors and compared them to the ground truth volume. With the best one, we call it the optimal, and this is what the distribution looks like for all cases. And generally, here around 2, so basically the simulated tumor has twice the volume of the fragmented tumor. This we consider okay with us, partly due to the skin effect, where we add a couple of voxels around a sphere, it's going to drastically increase the volume. So this is bad. There were outliers though, and these were regarded from further analysis. We also note that which parameters simulate the volumes. So there's one value for each case for D over rho and one value for D W dg that you best fit volume. And these are the distributions of those parameters. And it's pretty, this is to match what we expected. T overall covers the whole full range, but it seems to be localized at 5 or 20 millimeters squared. Whereas the WDG opted for a very high ratio, meaning that it preferred to be constrained to white matter. So to recap what we did so far, we took 100 cases of high-grade gliomas, or more than 100 cases. We segmented each the tissue with GTV. We used our model to simulate tumors, and we picked out the best fit checked all the parameters and used the best parameters for the remaining analysis, leaving us with 94 high-grade glioma simulations of what we consider to be good quality. So now the actual question we can start to think about. How would the conventional CTV methodology perform on these simulated tumors? Well, the goal of the CTV is to account for invisible cancer cell concentration. In CTV delineation for high gliomas, you typically add 2 to 3 centimeters margin around the GTV. 2 centimeters what were used in this study. So a perfect CTV, hypothetically, should encompass all tumor cells, and it should also minimize encompassed normal tissue. To investigate these two properties, we first looked at what we called C-enclosed, or C-encompassed, C-enc. And this is actually the lowest cell concentration isoline encompassed by the CTV. So for example, we have a GTV here in red. We're going to have different isolines of tumor distribution around it. And the lowest value that is fully encompassed by the CTV is equal to this C-encompassed. In this case, it would be 1,000. This means that the CTV delineation will mix regions with cell concentrations less than this value. So ideally, C-encompassed should be equal to 0. We also check the Hausdorff distance between the simulated tumor to the CTV. If you don't, or for those of you who don't know, the Hausdorff distance is a kind of a measure of conformity between two shapes equal to the greatest distance of all the direct paths between the two contours in some sense. So in this example, it would be perhaps dyx or dxy. I'm not sure which one is the largest. So comparing it to CTV, CTV is always strictly defined because it's just an expansion of segmented GTV. But our simulated tumor, it can take on different volumes depending on how we define the threshold of what constitutes tumor volume. Because in our simulations, the actual tumor cell concentration, in some cases, it encompasses the entire brain because it can also account for cell concentrations less than 1 cell per cubic millimeter, which have fractions of that. So if we cannot really set it to 0, we have to choose some value here. For example, here we have a segmented GTV in blue. Simulated isolines would be 8,000 cells, and we have a different volume for 4,000 cells, a different volume for 1,000 cells, etc. So the Hausdorff distance between the CTV and our simulated volume is not going to be the same if we use 1,000 cells as a threshold, or 4,000 or 8,000. So this becomes a function of the cell concentration threshold. Not wanting to leave anything to chance, we checked a range of values for this. So the perfect CTV should encompass all tumor cells. This means that C-encompassed should be close to 0. And the minimized encompassed normal tissue, which means that the Hausdorff distance should also be close to 0, in particularly for as low cell concentrations as possible. So how did the CTV perform? This is again a summary of the analysis so far. We include an analysis phase. We basically take all the simulations, we perform some optimization, take the best parameters, and we do the analysis of these metrics for the CTV. So, looking at C-encompassed, how did the CTVs perform in this case? Well, Here's the full distribution. And in 50% of the cases, C encompass was greater or equal to 614 cells per cubic millimeter. This means that these cases are going to miss regions of these cell concentrations or less. And in 84% of cases, we had C encompass greater than 1 cell per cubic millimeter. Whether this is acceptable or not, of course, it has to be decided on a case-by-case basis. And it can depend on many different factors. But regardless, looking at the Hausdorff distance, in virtually all the cases, the median Hausdorff distance is roughly 20 millimeters. But this is equal to the CTV expansion length. And here's some examples of what it looks like. This green outline corresponds to 100 cell isolines, so it's pretty low, actually. You see, it does not conform very well to the CTV in the first place, as is expected. If we conclude this, according to this model that we've used, the conventional CTV with delineation will typically fail to encompass regions of perhaps considerable tumor cell concentrations. And the conventional CTV delineations will conform poorly to the actual invasion. So I know I'm being perhaps a bit harsh to the CTV. It's doing its job as good as it can, but perhaps we can improve it. The brain is, of course, not homogeneous. So if tumor cells prefer to invade along white matter instead of gray matter, i.e. if this ratio is greater than 1, then maybe we could improve current CTV methodology quite easily if we just let it conform more to the white matter. Now I know what you're all thinking at this point. How do we even know that this model that we've used is accurate? Ideally, we would have histopathological data to which we could link it to, but we don't have that. So how can we even know that what we're doing is correct? The solution to this is what we're going to do in future studies. We can perhaps circumvent the whole problem and try to link results with real case data. So for example, let's say we have a patient at time 0. With some GTV, and we take and simulate what we get. And then we compare our simulated predicted tumor invasion with a follow-up of the same patient later. And then we can maybe check if there's some sort of relation there. This would be ideal for a network. And assuming we could get that to work, we might find some optimal parameters which we further feed into the model to get even better results. This would be a first step in perhaps getting a CTV tool that could help with delineating these cases. And even further in the future, perhaps if we get this to work, we might even be able to use a CTV that's better used for radiation. Perhaps using dose based on cell concentration planning. So we might have a PCP that depends on dose, but of course, we might depend on the number of cell concentration in this region. And probabilistic planning and so forth. But this is for the future. We haven't gotten this far yet. So, I want to thank you all for your attention. This is a picture of Stockholm, and I have some other people I would like to thank. Of course, my supervisor, Professor Glioma, and Associate Professor Marta Alfaroni, from Stockholm University, and also PhD student Media Staraki, who's been instrumental in the deep learning network side of things, and also Professor Cieli, and Science Working Group. Thank you, IOMP, for this chance today. So, thank you very much.
Okay, thank you greatly for the presentation, Wille, and for doing an excellent PhD work. That is actually of really utmost clinical importance. Because as I mentioned before, gliomas are one of the cancers where we are not winning the war on cancer, and by and large, the diagnosis is still a death sentence for a patient. I have got a couple of questions in the chat. I think some of it you might have covered. Do you see giving a uniform CTV margin around the tumor being a problem? Because as the studies show, and as you pointed out as well, there is a preferred direction of tumor growth, and maybe we should be using irregular CTV margins to improve the treatment outcomes. Could you comment?
Yeah, well, exactly. Well, first of all, I'm not an oncologist, so I have limited expertise in exactly how we should do this in practice. But exactly like this suggests, I think a good first step would perhaps to conform to the white matter tracts, or at least more to the folds and barriers of the brain, because this isotropic expansion seems to be very classical way of doing things that they have just expanded. It's perhaps easier said than done as well, because there hasn't really been many tools for this so far. But it seems that today, especially, we have more and more tools to be able to not only segment the tissue easier, but also to do these algorithms which can actually give this CTV this kind of shape. But it's something that we need some actual, experimental results before I think we actually do.
Right. I think we really should be monitoring the growth on the tumor if that data is available through MRI to identify what the preferred directions are. And maybe what you were showing, is there a role for artificial intelligence to tell us how to maybe predict the tumor growth and how to outline the margins?
Yeah, absolutely. I mean, that would be something that you could do as well. The way I see it is,
have there been any Monte Carlo approaches to this problem?
Not so far as I know. No, I'm not sure in what regard that you would take every single cell or. Oh no, I hadn't heard of that actually. That's a very interesting approach.
Now, in your growth model, you start with a certain number of cells and 0. How do you determine where to locate this and 0 within your segmented GTV? And will this affect when to stop the simulation and how well it will conform to the true GTV?
Yes, that's an excellent question. That was something that we discussed a lot. What we do is we place it at the center of mass. So assuming this GTV is homogeneous in mass, we place it at the geometrical center. The reason is basically because we had no real alternatives to how to do it. I guess in some sense, I don't know, even more to begin to do that in a more complicated manner. But we did this, and we also checked to be sure what happens if we change this center of mass, or we change the actual starting seed location. And it does indeed change the actual tumor distribution. It changes the simulation in some regard. To which degree, I don't remember the exact number, but it's something that would need to be further monitored. But basically, no, there's without any real evidence to do it otherwise, we're not sure. Where to do it. I mean, and it also depends a lot on what case you have. For example, if you have a tumor close to the periphery where there's a barrier, and you change it towards the barrier, it's going to change, a little bit how it grows. But we're hoping that the actual distribution of cells, the shape of it doesn't change that much. It's more as the absolute number of tumor cells.
Does your model take into account the different types of breast segmentation, like necrotic, edema, and different types of tissues?
In the deep learning challenge, we actually got segmented tissue for a tumor core, a necrotic core, and I think it was edema, and I don't remember exactly. But yeah, what we did was we let the tumor itself be equal to the contrast enhanced tumor plus the necrotic volume, and this seemed to also give perhaps the most realistic shapes. A problem was with the edema. We wasn't sure what to do with it, and it also seems to be a lot of uncertainty of how edema is related to actual tumor invasion. So we didn't include it in our analysis for that sake.
Clinical question: how can you differentiate between high-grade and low-grade glioma?
So we only got the high-grade glioma cases because they were already and they were identified in this challenge prior. So we didn't have to do that. So personally, I don't know, because I'm not an expert exactly on that. I haven't touched any low-grade gliomas. If somebody else knows, I would love to know.
Could you comment on the impact of different image devices for target visualizations? For example, which MR sequences are critical? Could radiomics potentially help with validation?
So yeah, this becomes a matter of how to segment the tumor, I guess, automatically. And to help with this actual segmentation tools in this challenge, they had access to, I think, all the different typical MRI modalities, as well as a CT, if I'm not mistaken. Of course, the more data you have usually for this kind of deep learning project, the better results you're going to get. Now, this whole project, I guess, what I have done from my perspective, if we were to find this tool, I am assuming that we wouldn't need to use actually an automated segmentation. I guess the vision I have, at least, is that if you let an oncologist actually delineate the GTV by hand, then they can apply this methodology to get the invasion.
To expand the CTV margin.
Yeah, exactly. Yeah. To make some kind of probabilistic CTV expansion.
Now, do you think that the CTV is really so relevant? Because you use combination, or the doctors use combination of therapies, and you will have your surgery, chemotherapy, radiotherapy. Wouldn't chemotherapy cover the cells, kill the cells that are not covered by CTV?
So, excellent question. Well, exactly. When we look at this samples distribution of cells we see here, I mean, I'm probably not imagining that somebody would make a CTV that is shaped exactly like this. So the way I see it is more like perhaps there are regions close to this tumor that we didn't expect before, or something like that. So we can maybe shove the CTV in towards that direction, or ultimately to get some kind of probabilistic dose planning. Because indeed, this is not something that perhaps would work ideally with the way we use the CTV, in that we have an that we have like an homogeneous dose distribution in the CTV. We'd have to, of course, account for that, because these are vastly different cell concentrations close to the tumor and far away. So I think it's more. I think I will give this tool to the oncologist, and I will let them do whatever they want with as they see fit best.
And of course, I think chemotherapy is sometimes a bit difficult. A, for solid tumors, and B, because of the blood-brain barrier. So the chemo infusion of the brain is not fantastic. So while the combined chemoradiotherapy increases the survival, it's still not a final solution. It seems that your prediction is applicable only when the GTV is small and infusion did not start in the initial stage. Do you agree?
It remains to be proven. We haven't tested this model extensively to see how it actually correlates with real cases for that regard. But yes, I think probably there's a good point with that. Many of these cases, we have quite substantial volumes. I'm not sure if I have any pictures of those here, but I mean, some of these GBMs, when we got them, they could cover up, a quarter of the brain. And indeed, we have to account for mass effect. There's edema. There's all kinds of issues at stake. Yeah, but the problem, or like the question is also, would those cases even be eligible for radiotherapy in the first place? And
has your work been published?
So it's in the process of, we have submitted it
Okay.
as we speak, yes.
Okay,
We will see.
so need to watch out for your name.
Yeah, it's coming soon.
Yeah, there is a comment here.
Yes.
Let me just, clinically, edema has been chosen to represent spread and thus the CTV. So for GBM, typically CTV is much larger than GTV, which your model shows that this is the trend. As you stated, histology is very important for these invasive tumors. So as a comment,
yes.
My question clear. In MRI full spectroscopy, data seems to show that the proposed equation does not correspond with reality. Proliferation can be extremely along a track going far away from the tumor, further than modeled with the diffusion and proliferation. Would you add another factor to your equations if necessary? And I might add that I actually sort of collaborated with neuropathologists who did histopathology on lots of gliomas, and he would tell me that the main tumor will be on one side of the head, but the recurrence will be on the other side of the brain, very far away from the original location, which would maybe support this notion that you might have a maybe very narrow elongated track and high mobility of the cancer cells.
Yeah, that's interesting. It's, I don't know, maybe it's related to, see, of course, one thing we haven't considered for this model is the fact that, you know, we have white matter tracts. There seems to be some sort of consensus that they follow these tracts along them. So you might want to add a diffusion term, a diffusion tensor term to this. Or another term, but it's not something that we considered because, first of all, we didn't have the data. But yeah, I mean, absolutely. The thing is, this model, we're open to all kinds of, if you have suggestions for improvements, because it's quite a simple model that we've used. We have all the data and it's fast to use. So we wanted to keep it simple before we you know, get ourselves over our head.
Yeah,
it's already very approximate. So
yeah. May I invite your supervisor, Juliana?
Absolutely, yeah.
Juliana, can you unmute yourself and turn the video on? Would you like to add anything to Will's presentation?
Thank you, Eva. Can you hear me?
Yes.
All right. Thank you very much, first of all, for allowing Ville to give this presentation. The only thing I'd like to add